So this lecture is on gastrointestinal disorders. Here are your learning objectives. We're going to talk about a lot of the strategies to manage common GI symptoms of the older adult. And then at the end of the lecture, we're going to talk about GERD and hemorrhoids. So here are the normal changes of aging that happen in our GI tract. And I tried to organize them here in this table by which parts of the GI tract that those changes happen in. So starting with the mouth and then ending up with the rectum. What you really need to get out of these few slides is that the first column is what normally happens with aging, but also what the consequences of that would be if it developed into a disease process. For example, if an older adult has diminished taste, which is a normal process of aging, that becomes a problem when the older adult overly salts their food, to increase the taste, or they simply stop eating because they can't taste, or because they just don't have an appetite because they have no taste. So that's how a normal change can affect a disease process or cause a disease process. So here's some more changes that happen in the intestinal tract. And here's the hepatobiliary system changes. Okay, so the last three slides, normal changes and then potential consequences. So try to answer these questions, if you'd like, using the previous three slides that I just showed you. So you're kind of using the table. Make sure you understand those age-related changes with the GI tract to answer test questions and also for NCLEX. For example, normal age-related changes in the first one, for example, with chewing or swallowing problems might be loss of teeth. That's a normal aging process. Decreased saliva, slow esophageal motility, so that you're beginning to really study how those age-related changes affect disease processes, symptoms, and things. Know the changes so you know what to worry about and things that you shouldn't really worry about. NCLEX does have a fairly heavy content on gerontology issues. All right, so these are the 6 main GI symptoms that older adults complain about. We're going to assess each of these to get as much information about them and then how to treat them. So we're going to talk about each one of these. So how to assess and then how to treat these common GI symptoms. So if we have an older adult who comes to the emergency department complaining of nausea, you give that older adult Zofran. They feel better, okay? And then we need to identify the cause of the vomiting. There's always something that causes it. And then we look at the signs for dehydration, okay? So normally patient vomiting comes to the ED, we give them Zofran. Then we need to try to find out what's causing their vomiting. And then we look for other complications of that vomiting, okay, like dehydration. The worst effect of vomiting and diarrhea is fluid loss. The older adult might lose a ton of water and electrolytes, especially potassium as an electrolyte. So we want to look for dehydration and those electrolytes very quickly and treat them very quickly before they become a big problem. Okay, so try to figure out what the cause of the nausea and vomiting is. Okay, so this is how we manage it. If an older adult has it or they come to the ED, we try to treat the underlying cause. Okay, so we identify it and treat it. It could mean having a CT scan or some blood work because nausea and vomit isn't a disease by itself, although it's symptoms of a disease. And the older adult, it can cause the older adult a lot of problems. So anytime somebody comes in with vomiting, we really need to draw blood work. If the older adult is dehydrated, we must get their fluid volume back up and try to get them to stop vomiting. So usually the older adult is NPO until they stop vomiting. Then we start with IV fluids with added potassium. Once the vomiting is under control, then we switch the older adult to a clear liquid diet. But we need to ID what they must be able to take in, or we must be able to make sure that they can take in enough fluids to support their fluid needs before we stop the IV. We can also give something for them to help with their vomiting, such as Zofran, which is IV or oral. And the oral is a disintegrating tablet, which is put on the tongue. So it's pretty safe and has very few side effects. The worst side effect from Zofran is that it can slow down the heart rate. So if we're already giving meds like digoxin or metoprolol to slow the heartbeat, beta blocker, then we really need to monitor their heart. Okay, if we give Zofran as well. Zofran does have a lot of drug interactions, and we should go ahead and call the doctor if that heart rate goes low. One thing, if you're giving Zofran IV, any medication IV, always make sure that you flush with saline afterwards so that they get the full dose of the medication. Okay. We treat we identify and treat the underlying cause. We make sure we replace those fluids. I'm just kind of, going through the slide here, what we've talked about. So NPO, then IV fluids, then a clear liquid diet when their vomiting is under control. If there's no dehydration, then they don't really need to stop. So if there's no dehydration, we try to use non-pharmacologic treatment. Okay, for them. So we don't really need to give them anything to stop the vomiting. We don't need to give IV fluids. We just keep them comfortable. And then, we can provide a fan. We can put a cool washcloth in the back of the neck, minimize unpleasant odors, the things that are listed here on your slide. An interesting thing is peppermint. Peppermint is a natural thing that can really help with vomiting and help ease the stomach. Okay, so that's if there's no dehydration. We talked about what to do if there is dehydration, and we want to make sure that we avoid things with a strong anticholinergic effect for the nausea and vomiting, such as those things listed on the slide here. Some antiemetics, these are antiemetics that we really want to avoid because they will cause significant side effects like sedation, urinary retention, blurry vision, orthostatic hypotension. So we really need to watch for falls. The first two are prescription that's listed here, the Phenergan and the Reglan, and the other two are over the counter. But again, they're anticholinergics, and we need to make sure that we try to avoid them at any cost in an elderly patient. So when we draw the labs, we do want to monitor and replace potassium if potassium was lost. All right, so abdominal pain. Abdominal pain is one of the hardest symptoms to manage because there are so many symptoms that cause it. So many disease processes, so many different things that could be happening in the abdomen. So the questions that we want to ask really help guide our diagnostic process. And we want to really be specific and try to question to get down to the root of what's causing abdominal pain. So the questions, are very important. So, we might want to ask things like the first couple: when did it start? What made it feel better? How would you describe it? At what, can you point to, exactly where it hurt? So that is the questions that are going to guide us to what's going on. For example, if the patient took Tums and it felt better, then we start to think that it's something from increased acid in the stomach. Okay, so what we ask is really important. Abdominal pain is so vague that sometimes, though, it's really hard to get good answers about it. Also with pain, we want to make sure that we have them rate their pain. Okay, ask them if it comes and goes. what do you think it is? A lot of times the patients will have a good idea of what it is. Okay, and then of course any associated symptoms. Okay, so good questioning is important for abdominal pain. Now, if you can imagine, this is sort of a map of the abdomen, okay, with the red star in the middle being the umbilicus. You can work your way around to see where the pain is coming from and then what might be causing the actual abdominal pain. We studied this in health assessment also when we were doing the abdominal lecture. It's really important when you're doing a physical exam too to know where those organs lie in the abdomen. For example, if we have pain in the right side, it's usually gallbladder, could be kidney stones or appendicitis. If the patient has pain in the left side, it could be pancreatitis, kidney stones, or something to do with constipation or or the bowels or maybe diverticulitis. Stomach ulcers or UTIs are usually in the middle. Urinary retention can also cause pain. So to palpate to see if the patient has a large bladder or a urinary tract infection is also a good idea for older adults. Anyone who comes in with abdominal pain, especially when it hurts to be touched, needs to go to diagnostic imaging. So we can do an upper abdomen, and they do this through an ultrasound, okay, or a lower abdomen can be done by a CT scan. The labs that we would need to get for abdominal pain, we really want to look at those electrolytes, liver function, and we do that through a CMP. We could also get a lipase level, especially if the pain is in the upper quadrant because of pancreatitis, and a CBC with differential. And that tells us things about infection or maybe a GI bleed or something. Many times abdominal pain is associated with a GI bleed, so that CBC is very important to check the hemoglobin. As for nursing management, we want to manage the pain, usually with opioids. We really want to avoid NSAIDs with abdominal pain because NSAIDs do really cause gastric irritation. And they can also cause a lot of GI symptoms such as bleeding. If there's nausea with the abdominal pain, we could give Zofran, as we talked about. We want to decompress the stomach, usually with an NG tube to relieve that pressure and really clean out the contents. Repositioning the patient can help sometimes. We can put them on their right side to help with heartburn pain. Also, if they're full, we can put them on the right side. It helps kind of move things down and moves those gas bubbles and things. Keep the bedside commode close, especially if they're having other symptoms such as diarrhea. The older adult with abdominal pain usually takes very shallow breaths, okay, and that could lead to atelectasis. So we want to make sure that we continue or have them do incentive spirometry and deep breathing and coughing to prevent atelectasis from that shallow breathing because the diaphragm moves, which might cause the abdominal pain to get worse. All right, so flatulence is the next GI symptom. And usually it's kind of funny to talk about, flatulence and farting and things. But if the older adult is really full of gas and they're not able to pass it, then that gas pain can be really intense. And they'll come to the emergency department. So we really want to do things and instruct the patient to do things to prevent that gas buildup. The most common cause of flatulence in older adults is increased fiber intake. Fiber is a good thing, but we can't have the older adult, and we need to educate them to go from like 0 fiber to 25 grams of fiber all in one day. We need to increase that fiber very slowly over a course of a couple weeks so that their gut gets used to it so that we don't have this flatulence buildup. Other causes of flatulence are vegetables like broccoli, cabbage, Brussels sprouts. Okay, to help prevent it, we have the older adult take Beano, and it helps break down the gas. Also, lying on their left side if they're having pain, or lying on their stomach, that helps those gas bubbles float to where they need to go so that they can be expelled from the body. Bicycle kicks can help move things along in the bowel. And also we can instruct the older adult to take Gas X. Okay, and that really helps for people with a lot of gas buildup. Okay, so simethicone. Okay, and the symptoms, of course, of flatulence are, belching, bloating, and a feeling of fullness in their abdomen. Diarrhea. This has several definitions, but basically it's increased frequency of bowel movements and can be categorized as diarrhea. Okay, so an increased frequency of bowel movement. Some definitions that require a certain number of stools per day or a certain volume of stools today. Older adults usually know when there's a change in their bowel habits or when they have diarrhea or constipation. So it's really important to listen to the older adult and take their symptoms seriously. They know their bodies better than we do. Okay, so to quantify, the diarrhea, there's a stool chart that we use that's called the Bristol stool chart, and it lists 7 different types of stools in terms of consistency. Type 1 stool is very hard, and type 7 is very watery. So any stool that is soft, loose, or watery, especially if it's more frequent than usual, can be considered diarrhea. The worst thing is that it can cause some pretty significant dehydration, just like vomiting, and vomiting and diarrhea together, very significant dehydration. The colon is where most of the water gets absorbed back into the body. So if the patient has diarrhea, then that water just isn't there. It's not getting absorbed in the colon. There are some more rare complications, like perianal excoriation, especially if the patient has very frequent diarrhea. It can cause breakdown of the perianal area. Fever and chills, if the patient comes to us with fever and chills with the diarrhea, could mean it's an infectious process, especially if the patient's ever had blood with the watery diarrhea. That's really bad. That's usually dysentery. And with the fever and chills, that's dysentery, and we need to get the doctor on board to treat this diarrhea as soon as possible. Food poisoning can also cause fever, chills, and gastroenteritis. Other causes of diarrhea could be antibiotics. Any new or altered dietary intake, heavily processed foods can also cause diarrhea. Okay, things that are spicy, fatty, or just the older adult having a lack of fiber. Fiber binds the stool together, so that's why fiber in our diet is very important. Tube feeding intolerance. Lots of people in the hospital or nursing homes may have tube feedings, so it's important that we get a dietary consult or the doctor on board. If the patient is having diarrhea from the tube feeding, we need to add some water to it to kind of cut that tube feeding a little bit. Inflammatory bowel disease, diverticulitis, Crohn's disease. With these, patients have intermittent bouts of diarrhea. And also, if they come back from a foreign country with diarrhea, we need to investigate the possible source of that. Okay, so definition, we talked about the Bristol chart. We need to monitor for that dehydration, excoriation, fever, chills. Remember, fever, chills could mean dysentery, some types of infectious disease going on in the bowel. Nausea and vomiting can increase diarrhea. And then we talked about the common cause. All right, so here's the Bristol stool chart. We can use this to more fully describe the stools that patients are having. So type 1 is very hard, type 7 is very watery. So management of diarrhea. Diagnostic testing is usually done. So we need to get a complete metabolic panel or a CMP. One of the issues with diarrhea is water loss, as we talked about, because water is absorbed in the colon, and the loss of potassium and bicarb as well. So we can end up with some significant hypokalemia, metabolic acidosis from diarrhea. So we really need to get those lab values to see, to make sure and prevent those problems. A CBC with dip to look at white counts to see if it's an infectious process, and also hemoglobin count. A stool ovum and parasite will look at things like worm infestations. A C. diff stool is usually getting, especially if the diarrhea is present after any kind of antibiotic therapy. And anyone with new or severe diarrhea that lasts for 3 months or more. Okay, think about C. diff. Okay, so new or worsening diarrhea, antibiotic use, diarrhea that's persist for about 3 months or so. Think C. diff. As for nursing management, we need to make sure that the patient has access to a bedside commode so they can use it very quickly. Help prevent and manage that excoriation. We can tell the patients to blot, okay, their rectum, not wipe. Okay, to avoid those harsh soaps, minimize or moisturize and put a barrier ointment on to help protect skin. Zinc oxide can work very well, like Desitin, in case of name. And then miconazole powder. Okay, our gut is really full of yeast, so miconazole can help prevent or cure a yeast infection that happens around the anus with severe diarrhea. These patients need to be on a clear liquid diet if they're having diarrhea. All right, once we kind of get the diarrhea under control, we can change them to what we call a brat diet. Okay, that's a very bland diet. Okay, so first clear liquids. Then the brat diet is bananas, rice, applesauce, and toast. Those are things that are very soft on the stomach, okay, not harsh. Rice, Sprite, or 7-Up can be given. Sometimes just that carbonation helps, relieve some gas and things. It makes the patient feel better. There's really no research to back, if it really does any good for the diarrhea, but it might make the patient more comfortable. And then saltine crackers help. Fecal incontinence. Okay, this is a condition that the older adult has. It's pretty rare, but it can happen. It's an involuntary discharge of stool. It's much like urinary incontinence, but it's just, as I said, much more rare. It can be chronic or acute. It can happen with or without diarrhea. It can directly affect the older adult's quality of life. Okay, it can isolate them. It can cause depression and then also anxiety. Much of the time, fecal incontinence comes with the patient having a history of laxative abuse. Okay, so we're talking about potential causes. So, which is actually pretty common, especially in older white females. So, laxative use or laxative abuse. Females in their 70s or older who grew up in a time when weight loss was really desirable and taking laxatives daily helped flush out, helped with weight loss. It helped flush out all of the toxins. It was very desirable. So fecal incontinence can be seen more in elderly white females because of this laxative use and abuse when they were younger. Nowadays, that doesn't really make much sense to us why we would take laxatives and stuff every day. But, it was a time that it was more desirable. It was just something that people did. Also, other causes could be, allergies or intolerances to food. Autonomic neuropathy is also an increasingly common cause. People who have had diabetes for a long time can also get autonomic neuropathy, and this has to do with the control of the sphincters, okay, and how the gut motility goes. Okay, so that's what the neuropathy affects. Basically, the gut and these things go into overdrive, and we can't control our autonomic nervous system, and we can get incontinence from that. People with Parkinson's or on Parkinson's meds can develop autonomic neuropathy also. Cancers, okay, or any sort of surgeries on the rectal or anus can affect the anal sphincter, okay, which could cause fecal incontinence. And the neuromuscular disorders can cause an inability to hold stool, such as, the dementia, stroke, Parkinson's, and spinal cord. to manage fecal incontinence, the first thing that we do is to gradually increase fiber. So we increase fiber. Fiber really has a lot of uses in the GI tract. It helps form the stool, so that the stool is harder, and it's harder to just kind of leak out, okay, of the rectum. Also, the best time to have a bowel movement is after meals, so we can take the patient to the bathroom after meals to reduce incontinence issues. We can help the patient identify triggers or warning signs, okay, of a incontinence episode. If the patient needs to wear incontinence briefs, like if they're going out for a long period of time, we can promote incontinence briefs when they're going to be away from the bathroom, and they're okay. But we need to really educate them. They won't hide odor, things like that, or maybe carry an extra one with them along with wipes, things like that. Incontinence care must be done the same as it would be for urinary incontinence. So mild soap, warm water, make sure that the area is dried very thoroughly. Moisture barrier ointments can be applied, or the cut down of excoriation. The miconazole powder we already talked about. And then we want to also monitor the stool for any changes in volume or consistency. All right, so constipation. Constipation is one of the most common GI symptoms the older adults have. It's decreased frequency of VMs. It's a Bristol stool type 1 or 2, okay, or any stool that's hard to pass. With constipation, we really want to monitor for things like abdominal pain, usually on the left side. Patients may have nausea or vomiting along with it, but usually the vomiting only happens if there's an obstruction or severe constipation. A universal sign for people who are constipated is decreased appetite. Also, if the patient has an impaction, okay, or some hard stool that's not able to pass, they'll have watery leakage of stool around that blockage, okay, or around that impaction. So it's important to watch. The things on your slide that I've listed are the most common causes of constipation. Again, fiber, let's just talk about fiber, draws water into the stool to help it pass. So low fluid volume, okay, can also cause constipation. So it's important that, and one of the treatments that we do, or we instruct the older adult for, is to increase their fluid intake. All right, so here we go. Increase fluid intake first. Okay, that's the first thing we do for constipation. Okay, things like warm coffee, tea can be increased throughout the day. That helps. Okay, or just drinking water. Increasing the fiber in the diet. So we could give a like fiber supplement. All right, but things just like increasing fruit, bran, can really help. Apples, grapes, and prunes, okay, are good foods, and they're promote a healthier diet as well. Fiber supplements like Metamucil can also be given, as I said. But psyllium fiber powder formulations do need to be mixed as soon as you're ready to give them, because if not, they'll turn rock hard, and then the patient needs to drink them right away. And the other important thing about psyllium fiber is to only mix them with the amount of water that it says to mix them with. If you mix them with more of the water, then the patient may not be able to drink that whole glass. So they're not getting the amount of fiber in the medication. Also, increasing activity helps move the bowel along. So things on your slide, like the swimming, bicycling, sit-ups, walking, really helps promote GI motility. A regular toileting schedule can help, okay, because the sensation and gets the body ready for it. It's time to have a bowel movement. Patients should not ignore the urge to defecate. That can cause constipation. We can also give a stool softener, laxative, or enema that we're going to talk about on the next slide. All right, so here is medications. Okay, the class some examples, and the nursing implications for those particular medications. So Metamucils we discussed. So people can take Metamucil like as a daily prophylactic, or sometimes patients will take Metamucil when they start to feel a little constipated. Okay, but stool softeners, okay, are given as a first-line medication, something like Colace. Anytime anyone is put on an opioid, we need to start the patient on a stool softener because remember, opioids can really constipate people. It's one of the most common universal side effects. Colace helps make the stool kind of pass, softens it, helps make the stool pass better. Stimulant laxatives can be given next, okay, that work overnight. We have the patient take the medication at night before they go to bed, and then usually in the morning after breakfast, it has worked. Okay, so that's a stimulant laxative. Saline laxatives work also, okay, kind of the same way, but they're a little bit more gentle. Okay, and saline laxatives, you'll notice that we do not give with impaired renal function. Okay, and also the stimulant laxatives, I'm just going to go up to something like Dulcolax. We wouldn't give those things either if the patient has hemorrhoids. All right, so know what disease processes is going on also. So hemorrhoids, if you have to kind of sit, what they do is they kind of stimulate the colon, and you don't want the patient who has hemorrhoids like sitting on the toilet or having that stimulation. It could worsen the hemorrhoid. Never, also milk of magnesia, okay, is a saline laxative. Never give to a person with renal problems. As we said, do not give with renal impairment. It can work in 2 to 6 hours, okay? So usually also with milk of magnesia, we might give it to the patient at noon, and then it kicks in and they can have a bowel movement before bed. Osmotic laxatives can be an alternative to like Dulcolax or milk of magnesia, but we can't give osmotic laxatives like lactulose to patients with diabetes because they have a very high sugar content. And if none of these laxatives work, and we might start out with one and see if the patient can have a bowel movement, and if not, we kind of move the way up. We also, when deciding to use these, how long has it been since the last bowel movement? There's things that we can do as preventatives, for constipation management, like the Metamucil and the Colace. If none of these work, okay, then we need to go to the enemas. Okay, so we start with a small volume enema, such as a fleet. These usually work in about 10 minutes, and they're water, saline, and other electrolytes. So how the fleet works is that it pulls water into the colon so the patient can expel the stool. The patient can hold the water from the enema as long as possible so that more of that water is absorbed, okay, into the stool to help it pass, or absorb from the colon into the stool so it can work better. If that doesn't work, we can use a large volume enema, which is about 500 cc's of warm water, and then soap suds and tap water. And the soap acts as an irritant to expel stuff from the bowel. One old treatment of a large volume enema, it was milk of molasses. And the use of that is really foolproof. So it's just that molasses plus milk plus water really softens and lubricates the stool. So you might, in some cases, see that given as well. Okay, so here's a review question. Okay, so go through this review question and see what you would suggest. Okay, see, abdominal pain. She's not dehydrated. Her daughter asked if it's okay for her to eat a few cookies that was brought in. Is that a good idea? And what would you suggest? Okay, diarrhea for 3 days, okay, with no abdominal pain. Okay, what do you think is going on? And how would you try to manage, all right, and prevent, okay, the symptom and prevent like dehydration and stuff from the diarrhea? All right, here's some other review questions that I'll have you guys just kind of go through. You don't have, just kind of think about them. Okay, this helps you get ready for test questions. All right, and there could be multiple answers. Okay, sometimes when we are managing GI symptoms, we know what the things that work the best, and we just need to get the patient information and determine what will work best for them. And if that doesn't work, what else we're going to try. Okay, so just kind of go through these questions with what we've already discussed here in the lecture. All right, so let's talk about GERD. GERD is a condition that older adults have, and it's a lot of reflux that goes from the stomach into the esophagus. There's usually 4 different problems that cause it, okay, and they're listed here on your slide. The esophagus can't empty. The saliva and mucus in the esophagus are decreased. So if we remember that mucus really is a buffer, okay, so that esophagus loses kind of its buffer, okay, and its protection, okay, because of the saliva and mucus are decreased. Loss of esophageal sphincter, control, or the lower esophageal sphincter could be weakened, and that causes that acid not to stay in the stomach, but to kind of prolapse up into the esophagus. And then pressure in the stomach, if the stomach is full or there's a lot of abdominal pressure is high, then that can push things from the stomach up into the esophagus. So there's 4 causes of GERD, and GERD is really just reflux from the stomach into the esophagus. And then basically the esophagus can't clear all of the acid, okay, that's coming from the stomach, so the esophagus gets really inflamed. Okay, so the esophagus gets inflamed with all of the acid that's in it, that's refluxing up. So if we remember back to anatomy and physiology, what happens with inflammation is that if the tissue is chronically exposed to inflammation, it'll undergo significant tissue changes. The cells actually change into other types of tissue, and the smooth lining of the esophagus, if this chronic inflammation goes on, will turn into kind of a rough lining, just like in the small intestine. Now, the small intestines is more resilient to acid, so it's kind of our body's way of protecting itself from that acid. But when this happens in the esophagus, we end up with it changing from one tissue to another. The patient can also ultimately end up with different cancers. All right, so, and Barrett's esophagitis, for example, it really does develop due to this chronic inflammation and the changes in the tissue that the patient has. And there's a 30 to 40% of the patients developing cancer from Barrett's esophagitis. Barrett's esophagitis is really hard to treat, and it causes a lot of pain in patients. One way that is a pretty radical treatment is an a removal of the esophagus. That's really the only way to treat it. Also, an esophageal stricture is another thing that can happen with this chronic inflammation and the changes in the tissue due to GERD. The tissue with esophageal stricture decides to turn into like collagen instead of a metaplastic tissue, as in Barrett's esophagitis. And the collagen makes the esophagus become really tight so that really nothing can pass through it. Okay, so the food just kind of builds up behind that constricture, because collagen, as we remember back to some of our other lectures, becomes really stiff, kind of really hard. Here are the risk factors, okay, for GERD. Hiatal hernia. In the picture, that's an example or a depiction of a hiatal hernia. Basically, the stomach prolapses through the diaphragm, And that diaphragm then puts pressure on the bottom of that kind of mini stomach. And the little mini stomach can hardly get anything into the actual stomach. So it really, everything kind of gets launched back up into the esophagus. People with hiatal hernias have a lot more problems with GERD. Anything that puts increased abdominal pressure, okay, like obesity, having tight waistbands, large abdominal mass, or cirrhosis are all things that can increase intra-abdominal pressure. Smoking is a huge risk factor for GERD, and many providers say that they can't really treat GERD without having the patient quit smoking. Certain foods may be a risk factor for heartburn. If the heartburn especially gets bad after they eat that food, what we do with trigger foods is just have the patient avoid them. And then also NSAIDs and aspirin cause more acid production, and some of them also shut down mucus production and bicarb production, which buffers acid in the esophagus, if you remember. All right, so we want to make sure that if we're giving NSAIDs, aspirin, or these tetracyclines, things, they can be a risk factor for GERD. Vitamin C also can lower the lower esophageal sphincter. Here are the signs and symptoms of GERD. Heartburn is the classic one. All right, chest pain can be a symptom of GERD. However, chest pain that feels like it's in line with the sternum or in the middle of the chest is usually associated with GERD. It could also radiate to the back of the throat. Chest pain that's related to a myocardial infarction is felt left of center. Okay, so the pain is in a different place. Frequent regurgitation, patients may say that they often have a bittery, salty reflux taste in their mouth. Frequent throat clearing means that the patient can't really get food down into the stomach, and that combined with belching may mean that there's a constricture going on, and it could cause dysphagia. The other things that are listed on your slide here are not associated with anything GI related specifically, but they have more to do with that acid in the throat causing inflammatory damage. And this usually, like the chronic cough, the sore throat, hoarseness, it usually happens more in the morning when the patient wakes up. If they wake up with these things, then it could be a GERD problem. But like I said, we don't necessarily always think of them as GI problem per se. And then usually symptoms are preceded by eating one of those trigger foods, also lying down in bed or bending over, that causes that reflex from the stomach to come up into the esophagus. Testing for GERD is rare. Maybe an EGD is done to look for esophageal damage, like in Barrett's esophagitis. We might do a tissue biopsy if something looks cancerous during the EGD test. So this is what the esophagus looks like if we do an EGD. The first picture there on the left is really a healthy esophagus, what an esophagus should look like. And then it kind of progresses with that chronic inflammation and ends with a cancerous or esophageal cancer in the very last picture. Medical interventions for GERD. Okay, treatment really focuses on avoiding those trigger foods and managing those risk factors. We can prescribe medications to help minimize damage to the esophagus with this reflux. The meds really focus on stopping acid producing, or at least really slowing it down. They don't help with increasing buffers like bicarb or mucus, but they can really slow down that acid production in the stomach so that it's not as caustic. There's not as much of that caustic acid that can be brought from the stomach into the esophagus. So the first two, the Pepcid and the Zantac, are the ones that we give most often. The PPIs, the proton pump inhibitors, are for people who have severe GERD to the point where they really do have esophagitis or constrictors. And those are scheduled medications like Prilosec or Proton. They're scheduled once or twice a day. They do not give immediate relief of symptoms. None of these do. So if someone eats a trigger food or does something to cause GERD symptoms, they can also take a Tums and they chew it up and swallow it, and they can take one about every 15 minutes until symptoms subside. Okay, so all of the medications are more scheduled medications, and they're not for immediate relief. Another thing I just want to mention too is that Tagamet. Tagamet should be avoided in older adults, so we should not give Tagamet, okay, to decrease that acid secretion as a medication for older adults. This is a surgical procedure to treat GERD. We used to do it a lot, but we don't really do the surgical procedure much anymore. There's no real need to, since we have the proton pump inhibitors, which totally stop the acid production. Okay, so it's really taken the place of this procedure. But basically what the surgical procedure does is it takes like that big flappy part of the stomach at the top, wraps it around the esophagus and kind of tightens it a bit. So this helps increase that lower esophageal sphincter strength because now that sphincter has like a collar around it. The collar could get too tight. So if the patient, after surgery can't really swallow good, then that's an issue. Also, they can't vomit. Okay, that could also be an issue if the stomach needs to decompress itself. A complication also of the surgery is that surgical line breaks and the stomach ruptures. However, this will, that's a perforation. This will occur usually immediately post-op. It is very rare. Okay, so it won't happen if the patient's had this procedure. That perforation won't happen like 30 years down the road. As for nursing interventions for GERD, it really focuses on teaching. Okay, the severity and frequency of symptoms we need to monitor for. Also, dysphagia is a swallowing issue, so we may have to treat constrictures or treat esophagitis to help with dysphagia. There's different things we can perform. The raising the head of the bed 30 degrees, the sitting up after someone eats, restricting food and drink before they lay down, the trigger foods, all of that. Gravity helps keep the acid in the stomach. So just by elevating those things is, or just by elevating the head of the bed at night prevents that reflux, or having the patient sit up after meals and not eat post bedtime can help with it. And also referral for smoking cessation, since it is a risk factor. All right, so lots of teaching here on your slide as well. I'll have you read through that. One of the things that I just want to point out, though, is if the patient doesn't have one of those automatic beds that adjust, into a sitting, they can put 6-inch wooden blocks underneath the bed frame or underneath the headboard, and that rises the head of the bed up to 30 degrees to prevent that reflux at night. Helps with gravity to keep that acid in the stomach. All right, so hemorrhoids is the last topic that we're going to talk about today. So the rectal vault, okay, or the lining of the rectum, has a lot of veins in them called hemorrhoidal veins. And if someone is, or as they age, as maybe they're obese, or with pregnancy, especially multiple pregnancies, there's a lot of blood that builds up in these veins. Okay, so those are some kind of risk factors. So there's blood that builds up in these veins, in this hemorrhoidal vein. And then those veins get congested and irritated. And this causes a prolapse either into the rectal lumen or through the anal opening. So this is a picture of hemorrhoids. Okay, the internal ones are in the rectal wall, and the external hemorrhoids and are encased with skin, and they're like the ones we saw in the previous picture. Okay, the internal ones are usually the hemorrhoids that will bleed. Okay, so hemorrhoids are just that hemorrhoidal vein due to different things like age, obesity, multiple pregnancies, really just gets enlarged and gorged with blood. So risk factors are anything that weaken the rectal wall, okay? So like multiple pregnancies, especially vaginal pregnancies that we talked about. Cirrhosis causes blood to back up from the liver back through the GI tract and into the venous system. So like the esophagus, the stomach, the spleen, the intestines, and the hemorrhoids. All right, so cirrhosis can be a risk factor. All right, any rectal surgery also can weaken the sphincter wall and can cause hemorrhoids. Obesity we talked about. Frequent constipation and straining with constipation can cause hemorrhoids. And then prolonged sitting on a toilet can produce a tourniquet effect. So a tourniquet effect on the hemorrhoidal veins. So it's like putting a tourniquet on your arm. The vein kind of pumps up with blood. It's the same concept with the hemorrhoid. The hemorrhoidal vein fills with blood and becomes very large. Okay, so these are some other risk factors. Signs and symptoms of hemorrhoids. Bright red blood from the rectum is a sign of a new hemorrhoid, especially if the patient wipes after a bowel movement. Pain also when they sit on their bottom. Itching and rectal prolapse in the later stages are signs and symptoms of hemorrhoids or later signs and symptoms of hemorrhoids. The distal part of the rectum also can push out through the anal opening. That's a rectal prolapse, and it's very hard to put back into place. And then fecal incontinence, because of the sphincter, it never really closes because of those enlarged hemorrhoids. As for medical interventions, are listed here on the slide. So fiber that we talked about, a stool softener, or some type of laxative keeps the stool nice and soft to avoid straining. We can do things like topical hydrocortisones, the witch hazel preparation H, that helps with the burning and itching symptoms. Some other things we want to make sure that we monitor, okay, for any kind of blood in the stool. Remember, bright red blood in the stool is from hemorrhoids. Dark blood is more from, or blackness is from the GI tract. We want to monitor for constipation, give medications, pain and itching, and provide medications to help with that. Give topical medications after each bowel movement to help with symptoms. A warm sitz bath that we're going to talk about on the next slide, how to give one of those. Ice packs can help decrease inflammation from hemorrhoids. Regular exercise helps move all of the blood through the circulation. Fluid intake, again, to keep the stool soft. And then all kinds of things that we can teach about, okay? And most of these things we've talked about that cause hemorrhoids, so we teach them to avoid them, and then how to use the medication. All right, so here's how to perform a sitz bath. Okay, warm water, because that's a nice calming. And you'll see in the hospitals and stuff, usually the things are pink and they look just like that and they sit in the commode. So we fill a bag with the warm water. You'll see it hanging on the side of the toilet there. The irrigation, comes up through the middle. The patient sits down on this bath basin. We open the clamp, and it just it's almost like a bidet. Okay, but we call it a sitz bath. And it really just kind of warms and helps with the inflammation, helps with the symptoms of those hemorrhoids. So we can provide a sitz bath for comfort. That is the end of the GI disorders lecture. I hope you all have a great day.